All right, well, we're going to go ahead and get started. So welcome everybody. Thanks for joining us for IPHA's third Thursday Lunch and Learn web series. My name is Brett Norris. I'm IPHA's communications coordinator. Thank you for joining us today. We've got a great lineup of speakers for this Lunch and Learn series this year, and today is no exception. This session is being recorded and it will be posted to IPHA's YouTube channel once we're done here. Before we go ahead and get started, just a couple housekeeping items. Your microphone should be muted during the presentation. Just help keep enough bandwidth for everybody to be able to see and hear the presenter. You can put your questions in the chat or Q&A features of Zoom. There will be plenty of time throughout where we can have some live discussion. You can take yourself off mute, turn your camera on, and ask questions that way if you'd like. Today, our speaker is Lexi Hack from the Iowa Department of Health and Human Services, and she's going to speak with us about the Stop HIV Iowa program. Sharon here is going to help lead the discussion in Q&A. And with that, I'll go ahead and turn it over to her and Lexi to introduce themselves and get us started.
Hi, I'm Sharon Miller. I'm the Director of Programs here with IPHA, and it's my pleasure and privilege to welcome you all and also to welcome Lexi. For those of you who don't know Lexi, she's been with the Department of Health and Human Sciences Services. I'm just going to say the old IDPH for many, many years. And fun fact about Lexi and I actually used to work together in a former life. Lexi was one of my valuable staff members. So it's been a pleasure to watch her grow personally and professionally, and now be able to call her a friend. So with that, Lexi, I'm going to hand it over to you and let you introduce yourself and then start this program.
All right, thanks, Sharon. I'm going to go ahead and share my screen. All right, and I just want to make sure everyone can see that. Brett, Sharon, if you can just give me a thumbs up or a shout out that everyone can see.
Yep, I can see.
Okay, perfect. So again, thank you for joining us today this afternoon to discuss Iowa's plan to end the HIV epidemic that we call Stop HIV Iowa. And again, my name is Lexi Hack, and I am an integrated disease intervention specialist in the special project division of the Iowa Department of Health and Human Services, Division of Public Health, and Bureau of HIV, STI, and Hepatitis. So I've been in this role really since February, but I previously worked as a disease intervention specialist, and this role actually does the case investigations for folks who are diagnosed with STIs or HIV. So in a world, I was a disease intervention specialist with the Bureau. For the past 6 years, I've actually worked as a regional health specialist, which is our academic detailing program, where we provide best practices on early education related to HIV, STIs, and hepatitis to a variety of different stakeholders. So that's a little bit about my role. Had a lot of changes really in the past couple of years with the COVID-19 pandemic, helped with COVID-19 contact tracing, worked with CADE and working on some of the death cases and data entry for that. And really got to work on just a lot of different pilot projects because our normal work kind of came to a halt. So we had to pivot and shift. So this brings me to my work now where I'm at as an integrated disease intervention specialist and special projects coordinator. And that special projects piece of my role will really be working on some pilot projects for the STI program, some process improvement that we'll be working on. So my background's in nursing, health education, health promotion, currently a doctorate in public health student with the University of Nebraska Medical Center. So that's a little bit about me, but let's go ahead and get started. So I have no financial disclosures or conflicts of interest with the material that will be presented today. And this is really what we'll work through today. And feel free to ask questions along the way. Sharon is going to be watching the chat for me and will have me pause if questions come up. We can also hold questions till the end. I always appreciate when we can have it be more conversational. So any opportunity that is welcome. So we're really going to look at the ending the HIV epidemic from the national standpoint, and then look at this from Iowa's perspective for our Stop HIV Iowa plan. We'll look at some national data and some data specific to Iowa in terms of what HIV looks like nationally and in our state. And then we'll really dig into our plan, kind of looking at how we set it up, where we are now, and where we're going. And then we'll end with any questions at the end. All right, so first let's talk about the national plan. And here I think is a really good overview of kind of how the plan began in September of 2019. And the CDC was awarded over $12 million from the Department of Health and Human Services to really put together ending the HIV epidemic plans. So this is kind of a view of what that looks like nationally. And so we had certain jurisdictions, states, counties that were deemed priority kind of populations based off of where, you know, we see the most cases and the most impacted areas to kind of get started. So this is really rolled out in a phased approach, and then other states would follow, but this is kind of how it got started. And this is the national HIV and AIDS strategy from the national standpoint with these 4 overarching goals. So preventing new HIV infections, improving those health-related outcomes for people already living with HIV, reduce HIV-related disparities and health inequities, and then achieve integrated and coordinated efforts. So that looks like a lot of collaboration, you know, is what that looks like between public health professionals, medical, people providing care to people living with HIV in a variety of different ways. So really that collaborated, coordinated effort. So again, these are just kind of the 4 overarching goals of the national strategy, and our strategy in Iowa also mirrored this. So the goal being to reduce, have a 75% reduction in new HIV infections by 2025, and then at least a 90% reduction by 2030. That is the overarching goal of the national plan. So here's just some information about HIV in the United States. So we know that more than 700,000 American lives have been lost to HIV since 1980. And it's important to note too that really this began in the 1970s when we think about it. We didn't know what it was at the time when we think about the HIV and AIDS epidemic, and it wasn't really until the 1980s that we were to, you know, give this a name and really know more about it. And we've continued to learn more about HIV and AIDS as we progressed over the years. We know that more than 1 million Americans are currently living with HIV, and that we know that more are at increased risk of acquiring HIV. And while the diagnoses have certainly slowed, it's important that without intervention, you know, to note that over 400,000 Americans will be newly diagnosed over 10 years, despite all these tools that we have available to us. And we know that the government spends over $20 billion annually in direct healthcare expenditures for HIV prevention and care. So what does this look like from a local level here in Iowa? So this is 2021 data. And we know that in 2021, over 3,000 Iowans were diagnosed and living with HIV. At the end of 2021, we had 124 new cases of HIV in 2021. This is incidence data for a prevalence of 96 cases per 100,000. And this graph just shows Iowans diagnosed with HIV from 2011 through 2021. And you know, here you can see what these numbers just look like over the year. And again, this is all incidence data, so new cases for these years. And you see that we had a peak in 2016 with 136 new cases. And then we had 4 consecutive years where we really didn't see an increase. And it was expected in 2020 that we would have a lower case count because of the pandemic, and it was expected that we would have a higher case count in 2021. So from 2020 to 2021, we saw about a 25% increase. But this is, you know, what HIV looks like in Iowa from 2011 through 2021. And this is the HIV care continuum. We have a care continuum every year, and every state has an HIV care continuum. And I want to go through kind of what these bars mean and what some of these acronyms mean. So the first bar that we see here on the left is represented by PLWH, and that stands for people living with HIV. So this, you know, little over 3,400 number here represents people living with HIV, and this is an estimation of folks we believe to be living in Iowa with HIV. And we know that it's an estimation. So through statistical modeling, through some numbers we're able to give to CDC, they're able to give us this estimation. So we know out of that 3,400 number that about 86% of that number are diagnosed. So that leaves this gap of about 14% that we believe is about 480 Iowans are living in our state that have not yet been diagnosed with HIV. And then as we move on to HIV diagnosed, we see that number is a little over 2,900. So folks have actually been given a diagnosis, they've had a CD4 count, they've had a viral load to show that it is an HIV diagnosis. And then linked to care within 1 month. So after someone is diagnosed with HIV, it's really important to link that person to an HIV specialist or infectious disease provider within 1 month. And so this is the best measure of health outcomes for that person living with HIV. So this is what that means. So that link to care within 1 month is 85% for this calendar year. This number changes every year. But if we were to look at this over a 3-month period, it would be in the high 90s, which is very good. And this is a very good link to care rate here. And then we move on to retained in care. So retained in care means that that person is able to demonstrate viral suppression by way of viral loads and CD4 counts. They're retained in care, seen a specialist on those antiretroviral medications. And then we move on to viral suppression. So a little over 2,400 folks are virally suppressed. And that means viral suppression, meaning the level of the HIV virus is below a certain number that HIV cannot be transmitted sexually. And this is important for a couple different reasons. So demonstrating viral suppression is the best health outcome measure for that person living with HIV and the best way to prevent new transmission. So we call this treatment as prevention. And we now have quite a bit of data to back that up too, that if someone is virally suppressed, they cannot transmit the virus sexually. So this is also called U equals U. I don't know if anyone has ever heard that term before, but it stands for undetectable equals untransmittable. So if someone has an undetectable viral load, they cannot transmit the virus sexually. So going back here, kind of what these numbers mean across the top. So of those diagnosed, 87% were retained in care. And of those diagnosed, 82% were virally suppressed for this calendar year. And nationally, Iowa actually does very well in our viral suppression rates. The last report that came out of states that submitted reports, I believe Iowa was in the top 3. So that's great. And I think it just speaks to the work of public health in collaboration and making sure that people living with HIV have the right support systems around them to obtain the best possible health outcomes. And I want to talk a little bit about the disparities that we see among HIV diagnoses among our priority population. So on the left-hand side, we see a pie chart, and this represents the population of Iowa. So I just want to note a few different racial groups here, but we see that 4% of the population identified as Black or African American, and then we see 6% of the population in this calendar year identify as Hispanic, Latino, Latinx, or Latina, I believe is the newest term, encompassing all folks of Latin descent. So when we look at this in terms of new diagnoses in 2021, we see that 16% of the new diagnoses were among the Black or African community, but representing 4% of the population. And the same here among the Hispanic population, representing 24% of the new cases, but really only 6% of the population. So this is where we see health disparities here. And it's important to note that, these increases are not due to sexual behavior. And the research actually shows that Black or African Americans in the Latinx population are actually more likely to use condoms and more likely to have fewer partners. So it's due to things like social determinants of health, health disparities, racism, stigma, historical trauma, all leading to reasons that we see disparities here. And we also see disparities among chlamydia and gonorrhea as well. Here's another slide of HIV by race and ethnicity from 2011 to 2021. And again, I think what this represents here is just the disparities we see among the different groups. And then this is by exposure category from 2011 through 2021. So the gold representing the total number of cases with each year. The blue, or the red, representing men who have sex with men, or also MSM. The blue representing heterosexual, brown representing people who inject drugs, the teal meaning MSN and PWID, and then the green representing risk not reported. So we certainly see disproportionately impacted populations by exposure category here too. So why is all this important? So I'm sure all of you are very familiar with our 10 essential public health services diagram that we have here with equity at the center of all we do. So really this effort for Stop HIV Iowa is really leading with our equity foot forward and looking at everything through an equity lens. And I just wanted to share a couple things that Iowa HHS is doing from a department level, and then what our Bureau is doing from just our level, specifically regarding health equity. So as most of you are aware, in July, the Department of Health and Human Services and Iowa Department of Public Health merged to become Iowa Department of Health and Human Services, or Iowa HHS. So here are some things that have been happening since the merger. So we now have a division of strategic operations and an office of equity. So we have Olivia and Diamond Denny, who are part of our health equity team there. Equity is a guiding principle for Iowa HHS. They're also working on a health equity work plan. And then we have a newsletter that comes out that just has an equity focus. So it's meant to be resources, trainings for folks across the whole department. And it's also a way to showcase the equity work that is being done across the state. So it's just specific to equity that comes out, but lots of opportunities to learn more. And then in our Bureau, we have a racial and health equity coordinator, Akoshwa Dasu, who is just specific to our Bureau. And it's been wonderful to have her. She really helps us in terms of equity, that all the work we're doing is through an equity lens. And she not only works across our Bureau, but also across the state with our contractors that we work with. So we have contractors in the testing field as well as the HIV care field. So the Ryan White program provides services for people living with HIV, and we have many contractors with us through that. So she's worked with all the Ryan White staff and then our outreach testing services, and kind of done what we call the health equity scans to really look at their work and see where they're doing great in terms of equity and in terms of opportunities for improvement too. And then most recently, Alicia Mercado, she is one of our academic detailers as a regional health specialist, but she has a focus on equity in her role for her academic detailing role, and she's located in North Central Iowa. And then part of our vision statement is also equity and social determinants of health. And one thing that we did in 2021, just specific to our Bureau and internal training, was we hosted a racial health equity challenge, and Akoshwa really led that for us. But it was an internal training that we did over a 6-month period, and we had 8 different units, all focused around equity. And we kind of went back to the beginning of the challenge, right? Looking at historical trauma, and every unit was different, and every unit addressed health equity. And we now have an internal Facebook page where we talk about things all related to equity and current events in equity too that are going on in our state and nationally. So I just wanted to highlight a few things that the department is doing to address equity, and then what our Bureau is specifically doing to address equity. And you'll see that outlined in our plan as well.
Hey, Lexi, in regards to equity, you have done a nice job of separating by categories, but is there any data that you can share with us in regards to rural versus urban, in regards to infection rates and access to care? Because as we know, sometimes it's harder to access care when I live in a rural community versus if I live in an urban community.
Yep, absolutely. That's very true. We know access is a huge issue in terms of equitable care. So some of the strategies that we've put in place for our Stop HIV Iowa plan also look at that too. So we're going to talk about the workforce focus area, which was one of our focus areas for Stop HIV Iowa. And that was one of the things we found too in terms of HIV specialists, right? So that position isn't in the rural parts, right? We see travel 2 hours one way to see your specialist. So what are things that we can put in place to make that care easier, accessing that care? And also what things need to be put in place for a tailored approach? So we have some of those things on our strategic plan and goals that we're working on. But yes, certainly that's a concern about equitable approaches and access to care, and how we can address that is always something we're looking at, right? Especially being in rural Iowa.
So Lexi, we have another question is, do you, the department, track stigma from an equity lens standpoint? Or is that something that you'll be doing in the future?
Can you say more about that question? I just want to make sure I'm understanding that. Or can you give an example?
Lexi, this is Lena. That was my question. I should have been clarified. It just made me wonder if there's a difference, if we see different types or rates of stigma associated with some of the different, whether it's geographic location, ethnic, racial groups? I mean, how are we tracking stigma and how that plays into treatment, diagnosis, whether or not people go to their, go to get tested?
Yep, absolutely. Yep, we certainly do see different populations that are impacted by stigma too. And in some of the rural areas, we see that too in terms of stigma. For the Ryan White program, they do a survey every year called a client needs survey, and then an experience survey, and they're able to offer feedback about maybe any stigma stories that they have experienced, really. And we in turn can take that back and say, what can we do about this? What strategies can we put in place? Who do we need to educate, right? How do we address that? And we also are actually working on an anti-stigma campaign right now, actually, with medical providers, and they're part of that team too, and why it's so important that, stigma has no place in healthcare, right? So why it's important for those champions to even educate from a medical provider standpoint about good patient health outcomes. So those are some things that we're working on across the Bureau too, and we're certainly aware of the stigma in disproportionately impacted populations that may be more impacted by that than others. And I feel like as someone who works some of the case investigations, I hear stories about stigma from patients here, and it's a common thing I think you hear about. So, how can we take that and turn that into education, and why it's important we don't stigmatize, and that STIs, they happen, and chlamydia is the most commonly reported infection, STI or otherwise, right? So how can we normalize that with patients, that if they were stigmatized, that we can work through that with them, and that we can put strategies and interventions in place? So I hope that answers your questions. Yep. Okay.
There's no other questions, Lexi, so if you want to move forward, thank you.
All right. Okay. All right. Just want to make sure. Okay. So now we kind of want to get into Iowa's plan to stop HIV in Iowa. So every state may have a different title for their plan, and we named ours Stop HIV Iowa. So I know there's a lot going on with this slide, but this really does provide a 360-degree-foot view of our plan that we laid out to stop HIV in Iowa, kind of providing that structure and the timeline. So we actually started in November of 2019, actually it was June of 2019, to begin to kind of put this plan together. And our community planning group, or CPG as we call it, is really our group that makes sure our Bureau is on the right track to provide inclusive and participatory evaluation to our Bureau. And they're really an informative group that has expertise in HIV, STIs, or hepatitis, lived experience, or may serve a population that is impacted by HIV. So this is really where our plan kind of came out of. CPG voted to move forward with this plan, and we began work on really the structure and timeline of our plan. And as we moved along in 2019, we were impacted by the COVID-19 pandemic. And so, kind of right at that point, we put a pause or a halt on our plan because of the pandemic. And some groups kept working through the pandemic, and some groups' work just came to a halt. But we'll get into that a little bit more, of the different focus areas that we have for our plan. But I just wanted to provide a slide that really kind of talks about the steps that we went through. So our structure, our planning efforts in step one, how are we going to gather the information to inform strategies and objectives to address our plan? And then how are we going to elicit feedback and then ultimately publish our plan? So this red circle right here represents where we are with our plan right now. So we are just getting ready to really kind of the final steps of our plan before it be submitted to CDC, but it's currently on the Stop HIV Iowa website, and it's open for public comment. Okay, so let's talk about some of the community engagement activities and really information gathering efforts that went into forming our plan. So in the very beginning, we formed 9 different focus areas that are what you see here, all devoted to stopping HIV in Iowa, kind of through this lens. So you see health equity is a big part of that, social determinants of health, behavioral health, addressing STIs. So we had 9 different focus areas that would all address stopping HIV in Iowa from this perspective. So I was part of the workforce focus area, and that means the workforce serving people living with HIV is what the workforce means from that area. So public health professionals, medical providers, from the care side, Ryan White folks, testing services, what does all of that workforce look like? So these are the 9 different focus areas that we went through, or that we had as a part of our plan. And we all did different activities to gather information, and some of us partnered together because there's overlap in some of these focus areas to deliver surveys and focus groups and key informant interviews. So I want to go through and kind of show you some of the numbers as we work through our gathering information phase. So for the focus areas, there were 3 different members of each focus area. So that represented a health department co-chair, a service provider co-chair, and then a community member, all for a total of 33 different members of our focus areas. We had our kickoff meeting in January 2022, and this was all virtual. We had over 170 participants that joined us for our kickoff meeting. And then through all of our information gathering, we had 18 different focus groups with 340 participants in those focus groups. And we also did key informant interviews with over 50 participants, in the 9 different focus groups, hosted a variety of those. And we completed 11 surveys across the state with over 2,200 people participating or responding to those surveys. And ultimately, over 3,100 people gave feedback in ways that we can address the Ending the Epidemic or Stop HIV Iowa's plan here in Iowa. So pretty excited to have that much response. So I want to go over just some things that we did in terms of workforce, and we partnered with these other groups that you see here with the medical care and support services, health equity, and behavioral health. Were all areas that we partnered with in some of our information gathering efforts. So I just thought we'd go through a couple examples of what we did to gather information, but know that many groups did similar things, partnered together to all gather information. So for the workforce, we're really looking at some different things as far as our scope, but do the demographics match the population served? What are ways we can improve the retention of the workforce? And how about the comfort level in addressing health-related issues and sexual health assessments, from providers to the patients, that comfort level? And then what are the additional training needs that are going to help ultimately better serve people living with HIV? So this was kind of the scope that workforce looked at. Oops. Okay, right here. And then these were our different engagement focus areas that we had. So we looked at primary care providers. We looked at adequate staffing. Do the folks that are working in this area have the knowledge and training to best deliver services for people living with HIV or at risk for acquiring HIV? And what can be done to recruit new staff working in this area? Where does compensation come into play? And then what is not working and what is working in terms of best practices? And can those be replicated and can those be shared with other agencies? So here are some community engagement activities that the workforce focus group did to gather information. And again, you'll see that we partnered with a variety of different groups. So for the focus groups, we partnered with behavioral health, medical and support services, health equity, and then the workforce group. So we hosted 3 different meetings across the state, and they were kind of specifically regionalized for our different Ryan White providers, looking at workforce capacity, staff burnout, and turnover. How is the structure of this, and how is it provided to people living with HIV? So we asked a variety of questions all along these focus groups. And then we also hosted 2 medical provider focus groups, again, looking at capacity, staff burnout, and turnover. And we also did a focus group with pharmacy. So the Iowa Department of Public Health, that's not current anymore. So our bureau, I'll say that, our bureau partnered with pharmacy focus groups, we have a relationship with the Iowa Pharmacy Association to provide outreach testing. And we have 12 different pharmacy sites throughout the state to provide this outreach testing. So they're also an important partner in this. So what does the workforce look like in terms of pharmacy testing, capacity, burnout, and turnover? And then we partnered with behavioral, medical, and support services and health equity for this focus group. And then we did a number of key informant interviews. So really looking at our Ryan White Part C providers. And the Ryan White Part C actually provides the medical care for people living with HIV. So again, what does recruitment, onboarding, retention, and capacity building look like within these agencies? And then for people living with HIV, we're able to perform some key informant interviews with 5 participants. So really looking at, what's working, what's not working, are we meeting the needs of those we serve among all these different priority populations that are here. So again, we partnered with behavioral, medical and support, health equity, and workforce for the key informant interviews. And then we had a number of surveys that we did too. So we surveyed respondents that work in HIV and hepatitis C, that survey. So that included infectious disease providers, Ryan White clinics, local health departments, our outreach testing, all the way from the front staff person, all the way to the administrator. Just understanding, what does onboarding look like? What does training look like? Retention, capacity building. And then we also surveyed primary care providers across the state, and we were able to partner with the Iowa Medical Board to help us get our survey out, and had over 400 respondents to that. So that included physicians as well as nurse practitioners and physician assistants, and partnering with those organizations too to help get our survey out too. So it was important too to have these collaboration efforts with these other organizations that could help us survey and gather more information to understand all of this too. And Ryan White always does a client experience survey and a consumer needs assessment survey. So we were able to partner with the Ryan White team, behavioral, medical, and support, and health equity to also survey these surveys that had already been done for years prior, but it'd be able to ask some questions in there specific to workforce that we're able to work with too. So some challenges and limitations with the survey. So there's some things we noted along the way, but the survey distribution to providers was a challenge. We know that medical providers are very busy, and especially during the COVID-19 pandemic, which continued on in 2021. That was hard just because their work was prioritized differently, right? And then the key informant interviews were a little more challenging than anticipated with people living with HIV. And then we did see a lower response rate for the client experience survey than was expected. So these are some challenges just in gathering some of that information. So to stop HIV in Iowa by 2030, so the workforce focus area identified kind of these priorities. So around recruitment and retention for staff providing the care for people living with HIV. There's training advancement opportunities were an area for improvement, as well as making sure the staff working in this field are adequately compensated, and ensuring that Iowans have access to infectious disease specialists, primary care physicians. Maybe this means reimagining some of that care for telemedicine. As we know, it's common that people living with HIV might drive hours one way to see an infectious disease provider or an HIV specialist. So access is a big barrier and an issue there. How do we, impact staff turnover and burnout? So these are all things that we identified as the workforce focus area to really focus on in addressing this focus area. And then here is our workforce focus area. This is hyperlinked, so I can send this out in a PDF, but it will take you right to our workforce focus area page. So I want to pause there and see if there's any questions about kind of what we've done to gather information in our engagement activities.
So feel free, ladies and gentlemen, to unmute yourself, ask Lexi a question, or if you'd prefer to just type it in the chat box, Brett and I will monitor that. So we'll give it a couple minutes so that you can all have an opportunity to ask your questions and or type. So Lexi, I'm going to ask you, was there anything from the findings that you had an aha moment with?
Oh man, I mean, I feel like so many things you know, and I will say that we were simultaneously doing all of our information gathering, all focus groups at the same time. So I would just say there's a lot of information coming in, and some of it we weren't surprised by the feedback that we heard either. But I think it was noted too, like I think just the good work that some of the organizations were already doing is like, oh my gosh, this is great. Like we could replicate this, we could implement this here and here, so I think systematic opportunities really came to light as to ways we could improve the workforce. And it is a training module a good thing, across the agencies that we work with. We have a manual for the Ryan White services, but can we expand on that? So I think there were just a lot of opportunities for improvement kind of on a systematic wide level that were just kind of came to light of like, oh gosh, this worked really well here, we could implement and replicate that. But I'll just say it was a lot of information gathering happening all at once because all the 9 focus areas were really doing all of this at the same time. So we had a lot of data and information coming in. And then, the next part of that is how do you streamline all of that and deduplicate to work on your goals and objectives. So, and that's where we'll go with the next part of the plan to kind of show where we're at now and how we went about doing that.
And I'm also wondering, Lexi, how much did you learn in regards to language and comfort of language? Because obviously when you talk about HIV, you talk about hepatitis, we got to talk about sex, and we got to say words like penis and vagina and discuss bodily fluids. Were some of that stuff brought out in regards to maybe some of the staff being uncomfortable approaching some of those subjects? Can you speak a little bit to that, please?
Yeah, absolutely. That was one thing that we found, that providers wanted more training on how to do a sexual health assessment. And, even just saying like, some of my patients might be offended if I do sexual health assessments. How do I approach that? What language do I use? So that was one thing we did identify is, I don't feel comfortable doing a sexual health assessment. I don't know how to ask the correct questions. And that's actually, a good thing for our academic detailers, our regional health specialist role, because that's what they do across the state, is provide education on best practices related to HIV, STIs, and hepatitis. So it's an opportunity for partnership, I think, there, and kind of understanding, where was the information coming from? Can we have a targeted approach to folks that are needing, is it primary care? What area is this information coming from the most? So yes, that was certainly something we found, is just the comfort level. I don't know how to talk to my patients about it. I don't have time. That was another thing too that came up. Or maybe there's a champion in my clinic and I typically defer that to my other colleague in the clinic. So yeah, there were definitely opportunities there identified around comfort level, and even just, other staff too, that just weren't comfortable, not familiar with best practices on how to talk to patients about a sexual health assessment, or, in what areas do you have sex? In what areas should we test you today? Just not even thinking like, oh, of course people have sex in different ways, but not even thinking like, oh, we should be asking those questions, right? So a lot of different things came to light, and opportunities to educate our medical providers and other medical staff too. Yeah.
Awesome. Well, thanks for answering my question, Lexi. We don't have any questions in the chat, so I'm going to be quiet and let you continue your presentation.
Okay. All right, there we go. Okay, so this really brings us to where we are now in our draft objectives and strategies for our Stop HIV Iowa plan. So again, our goals and objectives also mirror what the national plan goals and objectives were here. So here's the goals and their objectives under each one of these. And so really taking all of the information we collected and putting that into goals and objectives, and streamlining, deduplicating, marrying some of those that went together. So this was all a lot of work in itself to take all of that information across 9 different focus areas to put in goals and objectives. So of the different strategies submitted by the focus areas, we had over 260 strategies submitted, which is a lot, and it's amazing at the same time. So here you can see it broken down by the different goals as to the different strategies that the focus areas identified to address stopping HIV in Iowa. So again, putting all of this information together to our draft Stop HIV Iowa plan. And I just wanted to provide an example of what this would look like. So this is from goal 1, so prevent new HIV infections. But you see we've got an objective there, we've got strategies, and we've got activities. So this is really how our whole draft plan is laid out in this format. And it is on our Stop HIV Iowa website, and that draft can be found here. And it's currently open for public comment. So we'd love it if anyone wants to go there and take a look at our draft and provide comment. And so we're getting close to submitting our plan, but this is what the face of the website would look like, where you could provide feedback and look at our draft plan. So the next step is really meeting at the end of November to go over our draft plan, and then we will plan on submitting to CDC and HRSA on December 9th for Iowa's final Stop HIV Iowa plan. In total, it cannot be more than 100 pages. So you think about putting all of that information gathering and goals and objectives together to kind of break that down to 100 pages is also a lot of work in itself. So we are almost there, but a lot of work went into this with many different community partners and input from priority populations to really work on stopping HIV in Iowa. So that is kind of where our plan is now, but we are close to the final stretch there in submitting our draft plan. So that's a big 360-degree foot view of what that looks like in Iowa in terms of our ending the epidemic plan. But yeah, I'll open it now for questions, discussion.
So Lexi, if I have a question or after I read it, how long do I have? Do I have until next week to submit my comments? Because I know that this was really high level, but I know that there's some folks on the call today, the Lunch and Learn, that I'm sure are interested in looking at the plan. So they have basically until 2 weeks, right?
Yeah, pretty much 2 weeks. And I can get that exact date for you, Sharon, of when that will close, but we would welcome any feedback on our draft plan. Yep.
And I remember someone saying to you that feedback is a gift. So if individuals please take a few minutes, I know that, the holidays are next week, and I know that a lot of individuals will be out of the office taking care of themselves and taking care of their families, but this is really important. This is an opportunity for you to add your voice to this comprehensive plan to make sure that we don't miss anything. And as you know, everybody on this call, when you're looking at documents and grants and things multiple times, and you've read it and read it and read it, you get tired of reading it and you may inadvertently miss something. So please take a few moments to review the plan. I know that would mean a lot to all the individuals that have been a part of this process.
Yeah, I just dropped the link to the plan in the chat if anyone wants to check it out. Again, yeah, we'd love your feedback.
Does anyone have any questions, comments, concerns for Lexi? This is now your opportunity to ask Lexi, since she is our little expert here today.
Hey, Lexi, this is Laura.
Hi, Laura.
In my role as the Community Adolescent Pregnancy Prevention Program Coordinator for the state, need to keep thinking about youth involvement and how do we get youth a part of the plan. I know I've talked to a number of people within the Bureau about that, but keep us in mind. Let us figure out how we can help continue the plan in a way that we can get youth buy-in and youth involvement. And, we have all those restrictions that we have across the state, but I've talked to George and Colleen, so I think we're making progress, but how can we just keep us in mind? What do you think the youth output or the youth conversation should be? Do we have any good guidance from what you've learned?
Yeah, I would have to look more into that, Laura, as far as that goes, and probably George and Colleen are a good place to start with the youth involvement. But I would say the draft plan is open for public comment, so anybody can provide comment to that. So I would say if you work with a number of youth, they would absolutely be able to submit comment on that if they'd like. You know, and another thing, you know, we identified in our information gathering going back to youth is we know that Iowa's sex education is different and very inconsistent across our state. It looks different in every school district. So that's something too that we've identified is what does sex education look like, you know, K through 12, you know, and how can we improve that? How can we make an impact on that? So that is something that we realize too, is just, it looks different in every community, every school district.
100% looks different
Yep.
or non-existent.
Yep. Thank you, Laura.
All right, so I value people's times, including Lexi's, so this has been very informative. I know Brett's going to drop the evaluation link in the chat, so I would encourage you all to take a few minutes. The evaluation not only helps us and gives us feedback for Lexi, but it also helps us in regards to what we can do at IPHA to provide these lunch and learns for topics that are interesting and wanted and needed from you all in the field. And so that's truly what the lunch and learns are for, is, you know, we hear what you all say, and based on that, then we do our very best to reach out to individuals like Lexi to share their knowledge, their talents, and their skills with us. So Lexi, do you have any parting words before we say goodbye?
I just want to say thank you for having me today, and thank you to IPHA for providing this Lunch and Learn series. I think it's just a great way to learn about what's happening in public health across the state, a great way to network, a great way to connect. So just, I appreciate, you know, all of you being here today and learning more about what, you know, the state is doing to stop HIV in Iowa. So, and thank you all for the great public health work that you do. Whether you're starting out in public health, maybe you're a student, maybe you've worked in public health a very long time, but just thank you all for the work that you do.
All right, well, thank you, Lexi. Appreciate you sharing your expertise with us today. And thanks to all of you who came and shared your lunchtime with us. As Sharon said, we'd really appreciate it if you'd fill out the evaluation form. I just put the link in the chat, so it should be the last message. And our December Lunch and Learn will be on the 15th. And in that one, we're going to be joined by Bethany Snyder and Kenan Crow, who will talk to us about LGBTQ advocacy. So we'd love it if you could join us for that one as well. We're always looking for potential topics for future Lunch and Learns. I know we're still scheduling out some of spring and then next fall. And if you're interested in sharing your or others' work, you can email me at brett@iowapha.org. That's Brett with 2 T's. You can find my email or any of our emails on our website. And there you can also join or donate, which we'd really appreciate. Recordings of all Lunch and Learns and any other webinars that you might have missed will be archived on our YouTube channel. But I think that's about it. With that, thank you. We hope to see you next month. Thanks, Lexi. Thanks, Sharon. Thanks, everyone who asked questions.
Happy Thanksgiving, everyone.
Happy
And be well.
Thanksgiving. Have a good weekend.